Hello and welcome to the Nutritank podcast, where we interview leading experts within the field of food systems, nutrition, and lifestyle medicine. Our aim is to empower you, the next generation of healthcare professionals and change makers. We believe that the valuable knowledge and experience of our guests will inspire you to act and join the movement in creating a healthier population.
Hello everybody, Luke here, Nutritank member and nutrition student. We hope you enjoyed the previous episode where my co-host Ian interviewed Guy Singh Watson, the outspoken and pioneering farmer and founder of Riverford Organics. They discuss a wide range of fascinating topics from farming and climate change to how to make an impact in sustainability. They also talk about what Guy believes healthcare professionals should know about climate change and how we can all support climate change initiatives. Do check it out if you haven't listened to it already. In this episode, I speak with the brilliant Dr. Laura Marshall-Andrews. Laura's a GP in Brighton, and she founded the Brighton Health and Wellbeing Centre, one of the country's first integrated practices. It has a vibrant arts programme and complementary health team, and this practice won Innovators of the Year in 2014 National GP Awards, and was a finalist in the Kate Granger Compassionate Care Awards in 2016. She sits on the Council of the Royal College of Medicine and is a Fellow of the Royal Society of Arts. Created with the help of doctors, artists, and complementary health practitioners, Dr. Laura's pioneering holistic approach was revelatory. From those whose lives were changed by ineffective drugs to those whom alternative therapies, kindness, and trust proved transformative, her patients did all begin to flourish. Now, I'm just going to add a little disclaimer written by the Nutritank team. The NHS GP practice we discuss in this episode does use complementary therapies for their patients, but this doesn't mean that we're promoting all complementary forms of therapy here at Nutritank. And whilst the views of our guests don't always reflect the views of the company, we have to say that Laura's NHS practice has been thoroughly reviewed by 2 NHS England investigations, both of which have ended up with them saying this is a great practice. So with that being said, let's dive into the chat. So, Laura, welcome to the show. How are you doing today?
Yeah, very good. Thank you, Luke. Thank you for having me on.
It's a real pleasure, and I'm so excited to get into our discussion today. So, I thought just for our audience, it'd be worth giving a bit of context about how we know each other. I first met you at the IPMC conference 2023, and you were presenting on your Connection Works program, which I'm sure we might talk about later on. And yeah, it was really interesting to hear, really inspiring. I knew that I wanted to talk to you after watching the presentation. And I think my first question for you is integrated is a big word when it comes to your work. How does it feel to be attending and speaking at a conference which has got that at its core, a medical conference even?
Yeah, amazing, really. I mean, it feels like coming home. It's good to have a name for it as well, because I think when I first started the practice, when we took over the practice in 2013, and we started bringing artists in and different types of therapists, there wasn't really a name for it. It was kind of before social prescribing, before I was really aware of integrative medicine. I think integrative medicine was around, but it was quite niche and not that well recognized. So it's great that it's kind of gained some traction now and that more people are aware of it. And yeah, now that there's an annual conference in London all about it, and yeah, integrative and personalized medicine. So yeah, it's brilliant. I'm really happy that happens, and that it's, I mean, I think it has to be the way forward, really. I think that's where the future of good medicine lies.
Wonderful. And I think as a young person entering into that space, it's quite interesting and exciting speaking to the people who have been the flag bearers of integrated functional medicine. It's got quite a few names, and like you mentioned, the term, although it's now a lot more clearly defined, it has been called many things, different approaches with parallels. And the message we get as young people is, it's a great time to be coming in. You're riding the crest of this wave that people have worked so hard for. So I think, yeah, we owe a lot of gratitude to people like you who've pushed it when there has been, it's not been the smoothest path. Let's just say that.
No, definitely not. And I think it's it was very much on the periphery and kind of marginalized. And I think, in a lot of senses it still is. There's kind of integrative medicine, lifestyle medicine, functional medicine. They all occupy slightly different spaces, but they're pretty much the same thing, really. They all have a very holistic view on the patient, trying to see the patient in their context, and take that kind of full history from them, which involves their personality really a lot as well, and their lifestyle, and their previous events, as well as just the kind of classic presenting complaint and history of presenting complaint that we would take in medicine. So, I mean, one of the things that I really like the most, and I've done different courses in integrative medicine, functional medicine, and lifestyle medicine, and they all have just slightly different takes on it, but they have a lot of similarity. And one of the things I like the most is the functional medicine timeline, which kind of really looks back at a person's at life and at the triggers and the mediating factors, perpetuating factors in an illness, so that you can kind of see and help someone to see where their chronic disease or their pain or may have initiated, and that really helps people to understand what's happened to them, and then to look at more sustainable solutions to that, rather than just medicating potentially autoimmune disease or that kind of thing. So I think that there have been a lot of advances in the sort of frameworks and formulations around those different disciplines, which is really helpful, and given it more kind of kudos and recognition.
Yeah, absolutely. And just that image that comes to mind when you talk about that timeline approach is, I guess it's something versus the immediate medical treatment, it's that, lots of phrases get thrown around, but fire preventing rather than firefighting. And I think it's a really interesting approach and intuitive approach that hopefully we'll unpack a bit more in the episode. And as if I'm sure the listeners will, they leave this conversation wanting to dig deeper and find out more about Laura's work. I did, like I say, first hear about her at this IPMC conference, but I've also since read her book, which is absolutely wonderful. I really loved reading it. And it's called What Seems to Be the Problem. It's a collection of real, beautiful patient and professional stories highlighting the wonderful and unique lives of her patients, colleagues, and herself. All of these stories serve as a springboard, in my opinion, to bigger discussions about the failings of our health system, potential solutions, and most importantly, hope and looking forward. So a lot of the topics that I'm going to ask about today have come from me reading this book and being like, wow, really interesting, want to dig deeper on that. But I know I won't be able to ask all the questions I want. So I really encourage our listeners to read that. It's absolutely fab read. So our listeners may already know a bit about you from what I've described in the bio, or maybe they've heard of you before, but let's kind of, take a step back. And how would you describe your day job in its simplest terms?
So I'm very much still a practising GP, so I do a fairly normal kind of clinic. We have slightly longer appointments, and I get probably longer appointments because I tend to attract more complex patients. But I mean, it's a fairly standard setup. And what's different is that we have these other practitioners there who work alongside us. So we have HERA, which is the Healing, Expressive and Recovery Arts program, And that started very much kind of ad hoc with friends who were artists and things who started running groups. And then a lady called Emma Drew came along who was interested in it, and she has a master's in medical humanities, and she's an author herself. So she kind of took on fundraising and really developed a lot of governance and framework around the programme. And since then, we've attracted different artists, different writers, filmmakers, dancers, and we run a whole program which kind of varies from term to term or year to year, and that's all free for patients, free at the point of demand. It's largely funded by the Arts Council now, so we were recently made a national portfolio organisation from the Arts Council, so they give us recurrent funding for the next few years, which has been amazing because it's difficult funding all the time. But that's been hugely powerful for patients, helping people to come to terms with diagnoses or illnesses and treat their illnesses through non-pharmaceutical kind of solutions. And we've had lots of amazing feedback around that. I mean, one of the things that I always remember that really made me want to carry on doing it was this guy who suffered really bad Crohn's disease. He had most of his bowel removed, and he also had trigeminal neuralgia, which he'd had for a long time, which is, it's really very, very painful compression of the fifth nerve, so really bad face pain. And he said that he did the narrative groups for a few terms, and he said that what it helped him to do was to understand that he was bigger than his illness, and he'd kind of become lost, consumed really by his illnesses. And it just helped him to reestablish his sense of self outside that. And as he did so, then his pain got better, and his ability to cope with his Crohn's and his and the difficulties there dramatically improved. So we've had lots of that kind of feedback, which I think is really important. It's sort of seeing the patient as a whole and how their illness impacts on them, and treating them as the kind of host rather than just treating the illness and not really paying much attention to the person that's hosting that illness.
Amazing. I think, I find myself, and I'm sure most of our listeners as well, will be thinking, my GP surgery doesn't sound like that. So I think it's pretty amazing what you guys have done, and really groundbreaking as well. You talk about it as if it's amazing, but normal for you as it is. But this is, it's truly wonderful. And that pathway you described of that individual with Crohn's disease, and this kind of ripple effect, change in his mentality, change in his understanding, and therefore change in symptoms, is a very familiar story to me now, having read your book. It's like, there's this timeline, and whilst it might not always be that simple or that clear to follow that narrative, I think when you compare that to the alternative or the conventional approach, which would just be, okay, I imagine, I'm no doctor, but you've got Crohn's disease. What medications have we tried? What have you done? Okay, maybe we need to increase this or increase that. I'd like to unpack a bit more about perhaps when you started deviating from that conventional model.
Well, I first started thinking that there must be a different way of dealing with people when I was actually in my previous practice. And I was seeing a lady there called Elizabeth, who it's written about in the book. And I've seen her for a while. She had quite severe depression and bronchiectasis. And she would get recurrent pneumonia. She'd often be hospitalised in the winter and be on antibiotics for long periods of time. And she just had this ongoing fight with quite profound depression. And she came in to see me one day. I developed a real friendship with her, really. I really liked her as a person, and she came in to see me one day, and she just said that she'd found this incredible thing, and it was a singing group. that was local to us called Sing for Better Health, run by this lady called Udita. And so I didn't really think that much of it at the time, but just as I witnessed over the next few months this huge transformation in her, I got more interested in what it was and why it was having such an effect on her. And her depression really lifted. She came off a lot of her medications, and we went through a winter, and she got far fewer chest infections. She didn't go into hospital, and it was really quite a marked improvement in her mentality and in her physical symptoms. So I asked if I could come and meet the lady and come to one of the singing groups. And so I met Udita, who ran Sing for Better Health, and I wanted to try and see if we could incorporate that into the practice that I was working in at the time. But the partners there were very weren't very open to that idea. And so that really started making me think that perhaps I needed to leave that practice and start something on my own, where I could try these things out and see whether they really did have an impact or not. And then I was lucky enough to be sitting next to a GP at a dinner table, and she was run a single-handed practice, and she was just on her knees and said she couldn't carry on anymore, and the practice was struggling. They couldn't find any other doctors, so it was kind of perfect in a sense. And so my practice manager and I moved over there and took the practice over, and then brought Udita in as well as different people, and set it up that way. But yeah, it was really, I was taught that by my patients, and that's what made me interested. I think I kind of had that feeling anyway. I was open to that message.
Are you a healthcare professional looking to elevate your knowledge of nutrition and lifestyle medicine? Nutritank CIC wants to empower you to have the communication skills and knowledge of lifestyle medicine to improve your patients' health through free CME accredited webinars hosted every Monday evening. Learn from leading experts in the field and gain access to cutting-edge research and best practice. Here's what you gain through our webinars. Enhanced knowledge of nutrition and lifestyle medicine and applying it in clinical practice. Continued medical education credits to maintain your license. And free access to a library of previously recorded high-quality educational webinars. Take action now. Register for upcoming webinars or become a member at nutritank.com. The links will be provided in the show notes. Invest in your clinical practice and patients' well-being and fuel their health with Nutritank CIC.
Okay, yeah. Wow, I think it does take a willingness and a kind of vulnerability, I guess, to trust your patients more than trust your training. So it's quite incredible to hear that turnaround.
I think that's such an important phrase that you just said there, Luke. And I think one of the biggest barriers that we have to advancement in medicine, I think, is medical hubris and our arrogance as doctors that is instilled in us through our training, that we know more than people, and that you know more about someone's illness than they do, and you do know in some ways about the sort of the pathology perhaps, or the histopathic process, but they know what it feels like and how it is to have it. And so often you have patients who have gone to their doctor and said that they've got pain or they have these symptoms, and the doctor kind of will say, no, you can't possibly have that. That's not going to happen. And I think that's a real shame for us, because I think it prevents our learning as a profession, because we're not open. The whole thing about spontaneous recovery from illnesses. So people who have had very bad diagnoses and they've been given a poor prognosis and then they spontaneously recover. There are not many of them, but they do exist, and there are a significant number that we should really be paying more attention to that process than we do. And we just tend to say, oh, well, who knows what happened there, but they're okay, so we don't look at it. Whereas actually, we should be thinking, well, what did happen? How did that happen? And how did the fact that maybe they changed their lifestyle, or how did that, what impact did that have? But because it's not in line with our kind of understanding, we just ignore it. And I think that has really narrowed our understanding and hampered our ability to deepen our practice in a way that would be really helpful for us and for our patients.
Absolutely. And it's really interesting. I mean, I've got friends who are medical students just about to emerge into F1, F2 years. And I remember one friend saying to me when I was like, oh, like, how is it? I know a bit from family members about the stress of it. And he's like, we're just learning protocols. Like, nobody told me that medical school was just learning protocols. And I was really, I'm sure there's every medical school does their best to kind of not have that as their strap line. But it was really sad that was the student experience for my friend. And what I got from what you were saying there, that approach with regards to spontaneous remission, at least, was how did that happen? What impact did that have? And there's a really, it's so easy to see the difference there. One attitude is questioning, one attitude is curious, one attitude is not knowing, and the other is decisive, protocol driven. This is what's happening. This is what we've got to do. And it's really interesting to, I guess, in your opinion, does it take courage to sit in that space of unknowing? And why can't our healthcare system embody that a bit more, perhaps?
Yes, exactly. I think it takes sort of honesty, and actually, I think in my experience, and maybe it does take courage, I guess, but in my experience, patients often are perfectly happy with you saying you don't know. I don't know. I'm sure I don't know this, or I think most people understand that modern medicine doesn't have all the answers, and that we do just have a very narrow, quite an in-depth but quite a narrow field of vision on how the body works and how it dysfunctions, and I think people are happier with that rather than people either trying to kind of fudge around what they know, or just say, well, this is what we can do, and if you don't want this, then that's it. I can't help you. And I think it wasn't always like this when I started training. That wasn't how medicine was practiced. In the sort of 90s, when evidence-based medicine, although it has always been evidence-based, but that kind of the phrase of evidence-based medicine took off in the 90s, where you had to have double randomized controlled trials and everything had to have that sort of A-star evidence, and completely kind of devaluing patient experience and other forms of evidence, and really tying us to big pharma and the use of pharmaceuticals, which is one of the only things that you can trial with double randomized controlled trials, because you can't blind someone to that they're singing or they're doing yoga and that kind of things, and they're very expensive, those trials. So really only governments or companies or big pharmaceutical companies can afford to do them. So we sort of harnessed ourselves to the pharmaceutical industry when we did that. And we also took out, or we ignored the fact that people are really different. And when you do have these trials, you're looking at how do the majority of people respond. And so that can be something like 60% of people with ramipril did improve. Well, what happened to the other 40%? And how do you know the person who's sitting in front of you, are they one of that 60% or one of they 40%? And so what should you be using there, and why might that not work for them, and why might it work for them? And is there anything else that you can use? And perhaps there's something that might be more suited to them that might not be in the protocol. And perhaps you should try that as long as it's safe, or as safe as you can be. And so I think we've kind of, we're afraid to say now that medicine is largely experimental, but that is the truth. And a lot of the time, particularly in general practice, you'll be tinkering around with things with patients, like you might try a bit of this and a bit of that and see what kind of helps. And then you might end up with something that you're not quite sure why it does help, but it does, and it doesn't seem to do any harm. So go with that, and that's how medicine has always been practiced, and that's a much more real way of practicing medicine, because otherwise you end up in situations where you're putting people down a pathway that may be completely wrong for them, and that's never going to help them. And if you haven't got the ability to try and track it and say, well, is that really helping or it's not, or maybe they've done it before. The amount of times I see people who've just gone down the same loop over and over again, or they have this symptom, they get referred, they can't find anything, they get reassured, it goes away for a bit, then it comes back, and they just keep going around that same loop. And no one kind of thinks, well, maybe there's something different. Actually do something that isn't in a protocol, but that might help us deepen that understanding a bit. So I think the way that a lot of medicine is practiced now is very limiting, for the practitioner, for the doctor, or the practitioner, and also for the patient. I think that's why doctors burn out, clinicians burn out. It's not really, doctors work hard. They've always worked hard. It's such an amazing job. Usually you can cope with working hard. It's when you're working hard, but you're being forced to do something that you feel is not right or harmful even. That is, I think it's called moral injury now, isn't it? And it's, that's very difficult, and that makes you want to stop, and that makes you want to not do it anymore. So I think that there's, I think that if I was a young doctor now, I think I would say, protocols and guidance is just guidance. And although it is treated now as the kind of, the law, and that you have to do that, you don't. And, as long as in front of a GMC or a court, you can stand up and say, well, I made this evaluation, I looked at this evidence, and I discussed this with the patient, and they felt that they understood the potential risks and benefits of these different courses of action, and they went for this one. Then I think that's you're likely to be fine, and you're likely to have done the best that you can for a patient, rather than just saying, this is all that I can offer you, even if you don't want it or it hasn't worked for you in the past. I'm sorry, computer says no.
And you mentioned, I guess at the start of that, you mentioned arrogance, and in the computer says no, there is a degree of arrogance and there's a degree of complicity, but it's also the computer is what I've got to go off.
It's, fear of that you might be sort of ostracized from your profession, or that people will think that gone out on a limb, or you're not, that kind of thing, you might be struck off, or those kind of things. So you're putting a fear of your own professional stability in front of perhaps something that you think might actually be better for a patient. And that happens a lot, when people are like, well, I really think that this person would do well on this medication, or doesn't need this medication, but I can't prescribe it because I'm scared of what people might, what my regulating bodies might think. Or the truth is actually that the regulating bodies are far more, not lenient is the wrong word, but they will look at your process of decision making and your communication with the patient rather than whether you followed a protocol or not. And it isn't okay just to say, oh, well, this person came to harm, but at least I followed the protocol. And you feel that gives you some kind of defense, but actually it doesn't, and it shouldn't. It's a guidance, and you should still be using your own risk benefit assessment, your own research, and your discussion with the patient to inform your decision.
And that sounds, I don't think anybody's going to be able to disagree with that. But like you said, it does tackle something deep in us, that fear of professional stability, fear of kind of a loss of reputation.
Yeah.
And there's something inherently time consuming as well, I think, is an important point to touch on as well. It takes more time to ask questions than it does to follow protocols. And I think anybody who knows about the NHS or experiences the NHS from the inside or from the outside knows that time, waiting lists are a big issue or a big thing that the system is struggling with at the moment. I guess, how do we... is there anything that comes to mind when we think about using these approaches, but also fitting into the very pressurized system that we find ourselves in at the moment?
Yeah, I think that's a huge factor. You're right. But I think actually what tends to happen now is it's kind of efficiency over effectiveness. So we tend to move people through quite quickly, but not very effectively. So the amount of people who go round and round and round, and they're referred to physio say no, they can't do them, they come back to the GP refers them into the MSK, the MSK default puts them to physio, and physio saying, it kind of goes round like that. So actually these kind of processes can be you're having a short period of time with someone, you're trying to make a quick decision, but actually that decision isn't really that helpful, and it's putting someone maybe into the wrong pathway or down the wrong line. And it's better to try and you're actually saving time to put more time to front load that time and have a more in-depth conversation with them. But that's not the way that most practices are set up. The thing about general practice, though, is that you can set it up however you want. And that is the wonderful thing, just rather than hospital medicine, is that you do have a lot more autonomy in how you set your practice up. And you can offer longer appointments for people. You can sort of triage people in different ways. You've got a lot more flexibility in how you deal with your patient list. But, nevertheless, we are struggling. I think every practice in the country is struggling to deal with the demand at the moment. But a lot of that is related to patient expectation and over medicalization of people's condition or state, and that actually a lot of people will get better on their own without any medical intervention. But we've got, on the one hand, very, very high sort of standards and expectations, which are driven by governments and media and stuff, and then really an inability to deliver on that. And maybe a lot of the time what we should be saying to people is, don't go and see your GP, try and sort it out yourself first. But that's not the message that comes across. And it's like, oh, if you've got this, quickly go and see your GP, you need to get it checked out. And then on social media and things, you have stories of people who went to see their GP 3 times with a condition, and then they found out they had that gets circulated and everyone's really worried. You don't have all of the people who said, I went to see my GP 5 times about this, and then which is far more common.
Yeah, if that's one thing I took away from the book, although there is so much hope and so many reasons to be filled with confidence about humans' capacity to heal and to find a positive pathway, it's not simple. It needs to happen on so many different levels. There's so many things to be approached with different mindsets, and it comes, I guess, to sitting in that curious open-mindedness, but not certain place that we were talking about earlier. If anyone's won't be able to get a copy of the book, there was a little excerpt that I would love to read, which kind of characterizes that. When you said you arrived and it felt boring, I think it was really interesting. So yeah, I'll read that now. Okay. I found myself driving through the streets of something to start my first day as a GP trainee early one autumn morning in 2002, and was instantly afraid that I'd paid a heavy price for my changing career. Something consists chiefly of bungalows, and to my eyes that morning they were all grey. The sky was grey, the sea was grey, and the people who moved slowly outside them were also grey. All of a sudden, it hit me that I had undoubtedly made the biggest mistake of my life. There was nothing cutting edge about something. I'd walked away from the greatest sense of professional purpose I'd ever known. That was, I mean, that, like so many other bits of the book, is just incredibly well worded and really paints us a picture of your mentality at the time. And yeah, I'd love to hear just, I guess, those first few days that the wheels turning a little bit, and yeah, how different it got quickly.
Yeah, well, it got different. I turned around really quickly because I remember going up there and the whole thing was just awful. It was one of those really backwater practices, which just looked like no one cared about it, and there was stains all over the chairs in the waiting room and bits of A4 paper hanging off everywhere, and it just looked so uncared for, and I got into my room and just burst into tears. and then I had this sort of, in those days you had those Lord George notes, and I had this thing on notes, and I picked up the first note, and it was this old lady, and she was outside, and I think her going, oh God. And I called her in, and she was Marilyn Monroe's seamstress. And we started talking about that because she had pain in her hand, which is why she'd come in. And then she just had this incredible, colourful life. And I remember thinking, my God, what an arrogant person I was to have just looked at all these grey-haired people and just thought that they would be so boring, when actually, they were full of such interesting, funny, brilliant stories. And it just kind of got better and better after that, really. But it was the patience that made it really good. Whereas in hospital medicine, you've got a much bigger sense of your colleagues and being a bit part of a big buzzy team, and and that is different. And in most practices, you're still part of a team, but you do spend a lot of time on your own in your room, and you have to make a big effort to try and come out and have lunch and socialize with people, and that kind of thing. So yeah, but yeah, the patients are wonderful. A bit more challenging ones.
Yeah, absolutely. And I think, what you've said there about the professional purpose in hospital setting, feeling like a galvanized sense of team spirit, camaraderie, fast-paced moving things, I guess that was just what you associated with professional purpose at the time, and anything different wouldn't necessarily feel that will fit that mold. But I think the rest of your stories and the rest of that book is certainly proof that you found that professional purpose and more. And
definitely, and I think actually I'm much better as a GP because I think I've got that maverick soul where I've been more able to express that and to do things differently than I think I would have been able to do in a hospital setting. So I think I would have actually in the end found it a lot harder to be more constrained, which you definitely are in a hospital. So I think it was a fortuitous turn of events.
Yeah, and I think I don't know. I'm aware that in the medical profession, there's all sorts of generalizations about this speciality is this kind of person. They prioritize this specialty, and I've heard some pretty unkind things said about people who go into GP straight away, like they just want the easy route or something like that. And whilst it's certainly not the full picture, you did go into it because you wanted to spend more time with your child, and I guess GP is one section of medicine. Outside of that, do you think medicine lends itself to being a good parent as well as a good doctor?
I mean, it was the only thing that I sort of said to my daughter really was, if you can go into a profession, because particularly as a woman, the profession will look after you. And although it's difficult in a way and it sucks you dry and in a way, particularly the NHS, you do get your maternity leave. You can work part-time. A lot of my friends who went into advertising and PR and things like that, when they started having kids, they couldn't work part-time. And they had to then go through lots of different career changes, and it was much harder for them. Otherwise, I think, that's a great thing to do as a family, but you have to work part-time. I think probably most of what a lot of people do now. And it is, it's difficult, but things that are worthwhile are pretty much always difficult, and things which are difficult, are often worthwhile. And, it's really hard. I don't think you're ever going to have a job which is easy, which is what might bring us a sense of achievement and challenge. That's probably never going to happen. I think, it is, if you want to feel that you're doing something which is really good and worthwhile, then that is going to feel hard at times. But you can definitely work it out. And I think most people do. I think lots of particularly in general practice, but in hospital as well. You can work out your schedules and things so that you can have time with your family and with your children, probably more than a lot of other jobs.
Yeah. It does sound like there's that flexibility in the sense, but also I guess your journey is somewhat guided by what you have to prioritize outside of it. And you mentioned there difficult things being worthwhile. It's how many difficult worthwhile things can we fit in our lives? Being a parent and being a doctor, it's like those Venn diagrams can I imagine smash into each other a bit sometimes.
That's it. And I think, you can do a few sessions, and, lots of people do in our practice. We've got a few salary GPs who do a couple of mornings, and, then you can manage that pretty well for a few years and keep your kind of pressures, and then you can go back into it when the kids get older and stuff. So I think you can. I think if you're very ambitious, and you want to become a young consultant and make big changes and head up a department, that kind of thing, then that's gonna make it harder to to find the time to spend with your kids as well. But you just have to, something's got to give.
Hey everyone, I hope you're enjoying this episode so far and learning a lot. For those of you who are new listeners, welcome. If you're finding this information valuable, I would love for you to consider joining our regular listener family. Just hit that follow button wherever you're listening and you'll never miss a new episode. By the way, one of our main goals is to educate as many healthcare professionals as possible about the power of nutrition and lifestyle medicine. So if you know someone who might benefit from this information, whether it's a colleague, friend, or family member working in the field, please consider sharing this episode with them. Now let's get back to the show and dive deeper.
And it's been fascinating to hear about your journey through that, arriving in general practice. And I'd love to hear a little bit more about what your integrated practice looks like day to day. We heard a little bit about it earlier with the singing groups. That's how it got started. But what sets your practice apart, and what is it doing at the moment? What's happening right now?
So so we have this whole program that runs. So there's always these the arts groups. There's a calendar on the website, and people can drop into them anytime. They mainly happen in the waiting room or in the spaces in the practice, but we now rent out spaces outside in the old market just around the corner from us, and so those are the main things that we integrate with. We've got lots of social prescribers who help patients to access them, and then and we have ties with other organisations that collaborate with the practice. And then, as you mentioned, I think we were presenting at the conference was the trauma program Connection Works that we managed to get funding for a couple of years, and that was an incredible program that incorporated equine therapy, acupuncture, reflexology, and foraging walks, nutrition advice, different types of kind of therapies and things, all in a year-long program for patients with complex trauma, and lots of workshops around lifestyle medicine and things like that. So that was a really lovely thing to be able to offer patients in the practice who had trauma underlying their chronic disease. And the more you look for it, the more you realise that complex trauma underlies an awful lot of chronic disease, particularly things like chronic pain, fibromyalgia, stuff like that. There was a big link with trauma there. So that was great, and people seem to really do well with that, respond well with that. Got lots of people off medications, and there was some really good results from that.
Wow. And I mean, so yeah, that's inspiring, that root cause approach. And it's not necessarily a jump that, like we said earlier, most people feel comfortable making or investigating. How many people were you able to roll that program out for, and where was it rolled out?
So it was within our PCN, and we had 50 patients in each year cohort. There was a big batch, and we ran it for 2 years, funding to continue it. So yeah, it was about just under 100 patients, maybe 80 patients. Yeah.
And what were some of the takeaways from that? Of course, I think, at the moment I'm doing a placement for myself in the uni degree, working for a social enterprise, and I know just how fickle and elusive these grant-funded programs can be. And so it's often, we've done that thing, on to the next thing. What can we find now? But I wonder, as you sit in that space of reflection on that first study, what are your takeaways, and how would you like to see that work expanded upon and grow?
So I think one thing that we really learned from it was that that it was the group, in groups, and it was the effect of being together and with people over a year, experiencing these different things. That in itself was very powerful for people, and they often carried on within the group. And we see that in HERA as well, in the group work that happens. People work together and their narrative of what to continue, and after the course is finished, they'll remain together and continue doing something, or artwork or whatever on their own. And so that the power of the group, I think, was something that was really obvious, and we're going to try to bring it into our practice more and embedding that into our everyday provision of care, so that there are sort of menopause groups on PCN. We do some group stuff for transgender patients, and also we're doing group work for obesity as well at the moment. And we want to start kind of rolling that out more, so that actually people are offered a group consultation first, because although people often don't want that, it's actually hugely powerful. And it means that you can have 90 minutes with kind of 10, 12 people talking about individual experiences, but also about the condition that they have, sharing different things that have worked for people, and then you can do some individual kind of work with people as well. So actually, these longer group consultations, I think, are probably it's a really good way of helping give really good in-depth information to people, and you can see obviously a lot more people a lot more quickly. So and use the power of other patients and other people who are in similar situations. People have so much access now to knowledge and to different approaches online, that patients often have a lot of resource themselves that they can share. And that in itself makes you feel really good. That's a very positive thing that will in turn change your own physiology, because you're helping somebody else, and that kind of, fires off all those good hormones.
Yeah, to me it sounds like the perfect halfway house in between just purely community driven stuff left to their own devices and this sensible top down body of knowledge approach. And it just reminds me of one quote in your book. I can't remember who it was taken from, but it's that health happens in communities and hospital is for repairs. And when you do create this community, it's almost like health is just a natural destination. So it's wonderful to hear.
All the work about the blue zones, making people who have the longest lifestyle and the kind of best quality of life, and how they live, and more of the 9 areas with the longest life expectancies, that have this very strong sense of community and meaning and purpose, good diet, and using exercise as transport and that sort of thing, obviously really important too. But actually, connection, meaning and purpose, and community are the biggest determinants of good health.
Wow. And as sad as I am to say this, I think we're coming to the end. And so we're going to ask you the same questions that we've asked our other guests over the course of this series. And I'd love to hear, we've mentioned what it's like life as a junior doctor or an emerging doctor. And when you think about our audience, largely young healthcare professionals or young students, what would you say is one actionable tip for our audience to look after their own health or look after their own well-being on this journey of theirs?
I think hold it lightly, have fun, hold it lightly. I think, everything can be so desperately serious, and, we can feel this threat, fear thing in medicine a lot, like if you do something wrong, but actually, it's unlikely that that's ever going to come true. And, if you're just a good person, you do your best, and have fun and enjoy your patients, learn from your patients, enjoy them, have fun with them. For me, I think that was the thing that gave me the biggest resilience, was my relationship with my patients, and the joy that they brought, really.
And that could also be an answer to this second question, but it's, what's a strength you think we could all do well to cultivate to maximize our chances of creating a healthy future?
I think don't take yourself too seriously, and to learn from patients, and just meet patients where they are. Then there's a good chance that your patients are going to get better anyway. And so just trying to be with them, meet them where they are, and do what you can. Don't take yourself too seriously, and try not to be arrogant. And I think then that'll be the best thing for us, for medicine and patients to develop together in partnership. I think we have to kind of maybe step down off our high horses a bit and just, say we're just a guide, we're just there trying to help and support people and be humble.
Sounds like a pretty good toolkit of strengths there. And I'm going to answer this next question first with my own answer. So, resources that you can recommend to our audience. First of all, everybody, honestly, you won't be upset if you get this book. I think it's absolutely incredible. And I'm just aware of all the questions I would have loved to ask as well, relating to different parts of the book. For example, when Laura started the practice, what it was like bringing more complementary or alternative, in inverted commas, approaches to the practice at the time. There's so much I would have talked about. So it's, great place to start by reading that book. But Laura, I'm going to pass over to you now. What's one resource that you can recommend to our audience to learn more perhaps about what we've talked about today, or just to gain a bit of inspiration?
I think there's lots of resources, but at the Institute of Functional Medicine do a lot of free guides and things like nutrition plans and stuff like that, which I find really helpful for all patients. And then I think personally, as a practitioner, I love the Joyful Dancing Doctor. But she does kind of these little 10-minute boosts of kind of ecstatic dance and stuff, which is just fun and carefree and energy boosting. And I think that's a really good thing for us all to do who work in quite heavy environments, just to find some joy and abandonment.
Well, I look forward to checking that out. And as we wrap up, I guess, where can our audience find you if you use social media or learn a bit more about your work or support you?
So I am on Instagram, and it's Dr. LMA17, which is a terrible handle that was just generated for me by Instagram. But I'm pretty bad at using social media, so or just through the practice. But I'm sure I will pick it up if you message me through Instagram. That's probably the best thing. But it might not be very a fast response, but I will.
Fantastic. Yeah, really encourage our audience to check out Laura's work, and it has been a pleasure speaking with you today. Thank you so much for joining us on the Nutritank podcast.
Thank you very much for having me. Really, really appreciate it. Thank you.
We hope you enjoyed this episode. If you did, share it with your friends and family and drop us a review on your preferred podcast platform. Don't forget to follow the show on your favourite streaming platform and connect with us online to stay up to date with all the latest news and episodes. If you feel engaged with a particular aspect of today's show, then please comment on our social media posts for this episode. They'll be linked in the show notes. See you in the next episode.